Good morning, everybody. My name is Pat Levitt. I'm the Chief Scientific Officer and Director of the Saban Research Institute at Children's Hospital, Los Angeles. And at CHLA, we have a research institute that focuses on pediatric causes of pediatric diseases, as well as developing new interventions for those diseases. So I think most of you probably know that CHLA is well known for its remarkable clinical care, over 600,000 visits a year by patients who come to CHLA. We're very proud of the fact that we're a safety net hospital, which means that any family that needs care will get care when they come to Children's Hospital Los Angeles. And today we're going to focus on, this is a pre-science gathering. We have a science day that's going to happen in 2 days. And the focus of the symposium in the morning on Science Day is exactly what we're going to be talking about here. Diabetes, obesity, and heart disease whose risk starts in childhood. And for many disorders and diseases, the risk for those disorders and diseases begins in childhood. All of those diseases, fatty liver disease, cardiac disease, and as I mentioned, diabetes and obesity, have enormous economic impact and enormous impact on lifespan health and well-being for the individual. So the economic costs, as I mentioned, are pretty devastating. 90% of healthcare costs in this country deal with chronic diseases, many of them which I've already mentioned. So today we've assembled a panel of experts. They're both nationally and internationally known, who are doing research and innovative clinical care to change the trajectory for children. And I always say this, if you start early, the chances of being able to alter development to a healthier trajectory is so much more powerful than waiting until the disease occurs. And you're going to hear about that today. So I'm going to introduce our expert panel, my colleagues here at the Saban Research Institute at CHLA in a minute. I just wanted to let you know a few statistics. 100 million adults and nearly 15 million children account for approximately $150 billion in annual healthcare costs just for these three diseases. Obese children are 4 times more likely to develop type 2 diabetes than children with the normal BMI. Obesity-related fatty liver disease is the most common cause of chronic liver disease in children, affecting, and this statistic is startling, 1 in 10 children are affected in terms of fatty liver disease. And what you'll hear about as well is the disparities in risk for these diseases. 40% of Latino children with obesity already have fatty liver disease. So I want to introduce our panelists. I'm going to do it one at a time, where they're going to give a brief summary of their focus in terms of their investigations. So Dr. Santageorgia, hello, how are you?
Hi, good morning.
Okay, she's an investigator working here at the Saban Research Institute in the area of regenerative medicine, which is an enormous area of focus in the state of California because of the California Institute for Regenerative Medicine. Her research specifically focuses on what I think is among the most exciting ways in which regenerative medicine is going to change health outcomes, creating new insulin-producing cells using regenerative medicine. So, Dr. George, want to summarize a little bit of what you've been doing?
So my laboratory focuses on ways to think about how we can help people, specifically children with either type 1 or type 2 diabetes. Both types of diabetes in my lab's view are insulin cell centric. So we think about methods of how to improve insulin cell function and how to get insulin cells to make more of themselves, or how to make insulin cells from pluripotent stem cells as potential new therapies for patients with diabetes.
So that's very exciting. We're going to talk a little bit more about that in a few minutes. So our next expert panelist is online, Dr. Rohit Kohli. He's a gastroenterologist, a physician scientist who works on fatty liver disease and health disparities in Latinos. Dr. Kohli, can you explain your research that is impacting the health of children in a positive way?
Thank you, Dr. Levitt. We, for the past more than 2 decades, in my lab have been focused on unpacking, trying to understand how Not that I espouse doing weight loss surgery in children as a norm all the time. However, we do know that weight loss surgeries are very efficacious. They work well. And therefore, my lab has been focused on trying to understand how the surgery works so that in a colloquial term, we put the surgeons out of business. So we develop methodologies that pick at the best way to attack obesity, diabetes, fatty liver disease in children without them having to undergo these weight loss surgeries.
Thanks very much. Our next expert panelist, I want to introduce Dr. Michael Gorin, a great friend and colleague here at the Savant Research Institute at Children's Hospital, Los Angeles. Dr. Gorin in 2021 received $25 million to start a consortium in Southern California from the National Institutes of Health to study health disparities in Latino children in Southern California. The goals of this is to address health issues broadly, like Dr. Coley's work on fatty liver disease, in order to change the trajectory of children to go on to lead healthier lives. So Dr. Gorin, why don't you summarize what you've been doing?
Thanks, Pat. Well, the Southern California Center for Latino Health is addressing directly these disparities in chronic diseases that tend to occur together, like obesity, type 2 diabetes, fatty liver disease, which all start earlier in life. 50% of the population of Southern California is Latino, and 50% of Latinos born today will develop type 2 diabetes at some point in their lifetime. So the center is working closely with the community throughout the region to develop collaborations, to develop culturally appropriate interventions with those communities that we think will have a bigger chance of working to prevent the onset of these chronic diseases. Also, my work is focused on early life nutrition that we'll talk about later, I think, to try to understand how early life nutrition sets off children onto a trajectory of either good health or unfortunate health, and working to identify ways to improve early life nutrition.
Our final panelist, last but not least, is Dr. Elena Vidmar, and a clinician scientist who also has a focus on understanding the causes and treating with unique approaches obesity in children.
Thanks, Dr. Levitt. So I have the privilege of running our obesity medicine program here at Children's Hospital Los Angeles. We know that the rates of pediatric obesity have been increasing over the past 30 years. And if these rates continue, we know that by 2050, more than half of young people will be living in larger bodies. And while the size of one's body and the number on the scale is not what is important, we know that young people living in larger bodies have higher rates of developing life-limiting complications like type 2 diabetes, high blood pressure, high cholesterol, and like Dr. Coley said, developing collections of fat in the liver, all of which can lead to life-limiting complications and impact quality of life and health over time. Emerging science has taught us that individuals living in larger bodies have differences in the way that their body and their brain controls when they're hungry and when they're full. I like to think of it like a light switch, and the light switch gets sticky when it's moving between being hungry and being full, as well as differences in the way that their body controls what they do with the calories that they eat. Instead of using those calories as fuel, they take in those calories and store them immediately as fat. And so what we do here at Children's Hospital Los Angeles is that we have a comprehensive obesity treatment program where we integrate lifestyle modification, obesity medications, and weight loss surgery to try to help children living in larger bodies live longer, healthier lives. So I think the key to remember is that pediatric obesity is a complex chronic disease. It is a combination of biology and genetics and environment, and it is not the fault of the child or their parents. And we need to treat it with a comprehensive approach. So we need to combine lifestyle modification, which is looking at nutrition and activity, as well as incorporating things like obesity medications, which may come in the form of tablets or injectables, or potentially weight loss surgery, as is appropriate for the child. So using whatever tools we have available to help these young people live long, healthy lives and hopefully prevent them from developing these complications that could significantly impact their lives over time.
Thank you. That's a great summary. So I wanted to turn to you, Michael. Children's Hospital Los Angeles, over 70% of the families that come here are on Medi-Cal. We have a very large Latino population that we serve. I'm wondering if you can talk a bit about the issues around health disparities in the Latino community, particularly related to obesity, type 2 diabetes, and fatty liver, and what are some of the things that you're doing in the populations with this new Southern California center that are going to change the trajectory of development for them?
Right. So, for example, as I mentioned, 50% of Latino children today will develop type 2 diabetes. By age 2 years of age, we're already seeing disparities in obesity in Latino children who are twice as likely to be obese by 2 years of age. So we think there's something about the early life period that affects their future risk of obesity, diabetes, and fatty liver. Non-alcoholic fatty liver disease is particularly problematic among Latinos. That's a relatively new disease. Most liver disease used to be alcohol-induced, but the predominant form of fatty liver disease is non-alcoholic fatty liver disease, which has increased 62%. And we're seeing that in children as young as 5 to 6 years of age, which in severe conditions will require liver transplant. Part of that is also a genetic issue. Hispanics carry a gene called PNPLA3. 50% of Hispanics actually have that gene, which predisposes them to fatty liver disease. And other than genetics, there's also lifestyle issues. So, for example, sugary beverages. Latino children consume sugary beverages at twice the rate of white children. And also, we're looking at environmental factors such as air pollution and other obesogenic chemicals in the environment that can trigger the onset of obesity and diabetes and fatty liver disease.
I'm really glad that you mentioned the built environment, which we know has can have such dramatic impacts on risk for disease starting even prenatally, but certainly having an impact on child development, and we see that here at Children's Hospital Los Angeles. So that's a good segue, particularly your focus on fatty liver disease, to turn to Dr. Kohli. So Rohit, in addition to doing research in this area, we know you treat patients with this condition. Maybe you can expand upon that a little bit in terms of the strategies that are now being used clinically that came from research discoveries.
That's very nice of you to open that opportunity for us. In the clinic, in our fatty liver clinic, we are dealing with what I would call as a silent tsunami for Latino children. Dr. Goran just highlighted the numbers to put into perspective. If every other child who is of Latino descent is potentially being harmed silently by this disease called obesity-related fatty liver disease, then we are, in fact, struggling to keep up, right? If we have so many children being impacted quietly, it is really a tough nut to crack, so to speak. What we do in the clinic is we bookend. These are children. We're talking about 10, 12-year-old children who are coming to us from their pediatricians, primary care practices. We're trying to focus on the bookends of lifestyle, diet, and exercise. We have very strong data from multiple groups over and over again showing how sugar-sweetened beverages, sugary drinks, are one of the first things we should be trying to take away from the diet of these children, because the sugar that's absorbed gets stored, just like Dr. Goran was mentioning, as fat, especially with the genetic predisposition that these children have. And that fat then can become inflammatory and cause scarring and long-term liver damage. In fact, some of these children, when they become adults, are now part of the wave of the fastest growing population to get liver transplantation for as young adults coming from fatty liver disease. So we're definitely using lifestyle, but then we move on in certain individuals to start thinking of medications when they have inflammatory and fibrotic disease. And then if that's not successful, we have, of course, as the final opportunity to step in, even surgical interventions such as weight loss surgery.
So just a brief follow-up. So right now, there's no FDA-approved medication to treat pediatric fatty liver?
Correct. There's no FDA approved medication to treat fatty liver disease in children or adults. So right now we are definitely in the research phase. There's a strong push to look for a potential opportunity, and hence part of that push is from our lab, where we take something that works, which is weight loss surgery, try to unpack it and find the kernels, the signals that we can recapitulate without surgery and for the benefit of these children and maybe even for adults.
Yeah, and you really highlight why it's so important as we continue to do research in this area. And what's exciting about being here at Children's Hospital Los Angeles is the alignment of what we're doing in research that is really, the arrows are going both ways. The clinical challenges that we have, no approved FDA medications, is driving research, and then research discoveries are driving what we're going to do in clinical care. So that's a wonderful symbiotic relationship. So I wanted to turn to you, Dr. Georgia. And I've heard this term, I know this term, pluripotential cell, meaning a cell that can turn into any other kind of cell. And your research in stem cell and regenerative medicine is so innovative. Maybe you can talk a little bit about the progress that you're making in terms of creating insulin-producing cells, which has been the huge challenge in terms of dealing with type 1 and type 2 diabetes.
And so here at Children's Hospital, we're really lucky to have not just an ethnically diverse population of patients, but also a genetically diverse population of patients, where we can really try to use their clinical conditions and their clinical outcomes to understand insulin cell development, insulin cell function, and try to develop new therapies to treat that. And so what we do is to use cells that come from our patients and try to understand how it is that they differentiate into insulin-producing cells and how we can improve that insulin production and insulin cell function, and then use that information to try to translate that into new ways and new approaches to generate those cells for patients in the future.
So is it the case that one of the goals is to be able to take these insulin-producing cells and put them into patients, or is it determining through research how you can stimulate regeneration of the cells that the child has, and then be successful in producing insulin, or is it a combination of both?
It's a combination of both. For patients that have type 1 diabetes, they have an autoimmune disease that actually attacks and kills all of their insulin cells. So when we're thinking about how to replace those cells, we are actually thinking about creating cells outside of the lab and developing ways to give those cells back to those patients. We also have to work in partnership with immunologists to try to understand how to change their immune function to not attack these new cells. At the same time, for patients that have other forms of diabetes, like type 2 diabetes, they actually have insulin cells, and their body can potentially make more of them themselves without having to supplement with new cells. So what we are trying to do is trying to understand how your body responds to signals and to make new insulin cells by themselves, or how we can use different approaches to get those insulin cells to function better than they're functioning at the time.
And we're going to touch upon that a bit that you just ended with a little bit later. But I wanted to, Dr. Vidmar, you mentioned medication and weight control. So I wanted to have you expand that a bit in terms of practice here at CHLA and your views about that. We hear a lot about it in the news, about weight loss medications, generally apply to adult populations, not really thinking about how it applies to pediatric populations. So maybe you can give us some sense of where we are in terms of using medications.
Yeah, absolutely. So in alignment with the American Academy of Pediatric recommendations that came out in January of this year, here at Children's Hospital Los Angeles, we have a comprehensive obesity treatment program. So we integrate lifestyle modification, which is working on changing the home nutrition environment, as well as emphasizing emphasizing activity and movement, but we do as well incorporate obesity medications, which can be in the form of tablets that children and adolescents take or injectable agents, as well as considering bariatric surgery when it is appropriate. I think, as I mentioned before, the most important factor is to remember that pediatric obesity is a chronic disease. So it is not the fault of the child or the parent, but it is biology that is different, and there are things in the brain and in the body that are not working as well as they could be. And so I think of changes in the nutrition and medication and surgery as tools that we can utilize to help the bodies of these young children that are living in larger bodies to function more effectively. And again, the goal is not a size of a body or a number on the scale, but the goal is to prevent and treat life-limiting complications over time. We're trying to help these young folks to live longer, healthier lives, and hopefully to prevent them from getting these complications that could significantly impact their health trajectory over time.
So it sounds like a lot of approaches that we use here at Children's Hospital Los Angeles, very multidisciplinary approaches to any particular disorder or disease, because we recognize that there are multiple systems that are always involved. So, Dr. Coley in Philadelphia, I wanted to extend what Dr. Vidmar was talking about in terms of medication, and I know that there's some preclinical studies going on that you're involved with in terms of developing medications. Maybe you can give us an update on how that looks, both in terms of the work you're doing and the colleagues that you may be working with around the United States.
No, I'm happy to, Dr. Levitt. This is a very intense and active field of investigation, as you can imagine. Individuals such as ourselves are focused on developing new therapies, and the targets we're looking at could be broadly divided into 3 buckets. First one is more looking at weight loss as an overarching way to attack diseases that come from being overweight and obese, which Dr. Vidmar, of course, mentioned already. Some have recently been approved for treatment of obesity, being overweight in children. The second and third buckets are more focused on the liver and the damage happening inside the liver itself. I like to think of them as what's happening today and what may happen tomorrow. So the first thing that happens when you have a house guest you don't like, which I like to think of increased fat content in liver cells as a house guest you don't like, you start to develop an inflammatory reaction to them. And so certain drugs are being targeted to suppress that inflammatory response. And then the final version is when there's already been a fist fight between you and your house guest, so to speak. There's already damage on the cells. There is scarring, there is damage such that there is going to be long-term acrimony. And to reverse that fibrosis, that scar tissue, to take it away, is the third group of drugs that are being developed. We in our lab at Children's Hospital Los Angeles have been focused on bile acid signaling, which is more of a satiation, telling our brains, the gut, telling our brain when to stop eating. And that process itself has some downstream effects on the second bucket I talked about, which is inflammatory. So we are trying to contribute both in the second and somewhat in the third bucket, the anti-inflammatory and anti-fibrotic parts of the effort. But overall, it is definitely a lifestyle, like I mentioned before.
Well, it's unlikely that research is going to get rid of that annoying house guest, but research will will have an impact on what you're talking about in terms of trying to deal with accumulated fat, if starting in development and in pediatric populations, which, as you just summarized, is a really hot area of research here at Children's Hospital Los Angeles, and I know you have colleagues and partnerships and research around the United States, which is very important. Research is a team science, and so thank you for that. So I wanted to change the topic a little bit because this is also a hot area. So Michael, the influence of early ingestion of sugars developmentally has been written about in the news. And there is maybe some misunderstandings about it. Maybe people don't really understand how serious it is. And like you've done a lot of work in this area. So why is ingestion of sugar early in development so potent from your perspective? And what are the kinds of things that we need to be thinking about in terms of eliminating particularly processed sugars from the diet?
Yeah, the most recent dietary guidelines for America, for example, recommend 0 added sugars for infants between 0 and 2 years of age, recognizing the impact of how early exposure to added sugars. We're talking about added sugars or processed sugars, as you said. We're not talking about sugars in whole fruit or sugars in dairy. We're talking about sugars added to food. 80% of processed or packaged foods that target children contain some type of added sugar, which can have over 200 different names and can affect all parts of the body. One thing we're focused on is early life exposure to sugars. For example, we know breastfeeding is protective in a dose-dependent manner, but 75% of women eventually will turn to formula at some point. But yet, surprisingly, 50% of all infant formula has added sugar and is made with corn syrup and not
Can you repeat
lactose.
that so that everybody understands that statistic again in terms of the relationship between baby formula and corn syrup?
50% of all infant formula purchased in the US is made with corn syrup and not lactose, which is the natural sugar found in milk. So, and our research is showing that early consumption of corn syrup by the infant sets off a number of different reactions that increase risk for future development of these chronic diseases that we're talking about.
So what are the issues, as the infant goes to toddlerhood and toddlerhood to young childhood, what are the issues there around continuing to ingest sugars in a child's diet?
Yeah, so from formula, then we have the transition milk products, and then juice itself, which contains, although it's fruit juice, so it sounds healthy, it actually contains a lot of what we call free sugars, which is sugars liberated from the natural source. So, for example, a glass of apple juice will have the equivalent of 3 apples worth of sugar, and it's mostly fructose. And fructose is the sugar that gets taken up by the liver and eventually can damage the liver. And then there's now energy drinks, which are very popular and aggressively marketed towards children's, and sports drinks, all of which are high in added sugars and can impact metabolism and risk of chronic diseases.
What about sugar consumption during pregnancy? Yeah, I know you've worked on that as well a bit in terms of, are there effects that start even prior to birth in terms of the impact of sugar on the development of the brain and body?
So yeah, prenatal nutrition or just nutrition during pregnancy, vitally important. We know from studies that high levels of sugar consumption during pregnancy can also affect the developing fetus, as well as we haven't mentioned alternative sweeteners. So there's several studies, for example, that show that consumption of alternative sweeteners like diet soda during pregnancy can increase the risk of early onset of obesity in the offspring.
Thank you. Wanted to move to before we do a summary of the panel. Thank you all, by the way, very much for the really some new information for me. And I thought I knew everything, but I obviously don't. We've heard a lot about the impact of the pandemic on child health. A lot of it related to mental health, increased anxiety, increased depression, children at various ages. Not a whole lot about other health issues. So, Dr. Georgi, maybe you can speak to that, because I know you've got a really interesting and really important research program in this area to try to understand the impact that COVID had on changes in health and well-being for the child related to the topics that we're talking about today.
So my work here at Children's Hospital is really unique because I'm embedded in a clinical division, and I have very close relationships with my clinical partners here at Children's Hospital within the Division of Endocrinology and our Center for Endocrinology, Diabetes. and metabolism. And so I get the opportunity to work closely with them and learn a lot from them. And during the early days of the pandemic, our clinical colleagues were noticing an uptick, I should say, in children who were presenting with new onset type 2 diabetes and a really severe and sick presentation with a co-diagnosis of severe diabetic ketoacidosis, which means that
That's a big word.
right, which means that they were accumulating some blood products in their blood that were making them very ill. And so we did the work to look at how many children we had seen in the past prior to the onset of the pandemic come in with this, and we saw about a 10-fold increase in the number of kids who were presenting just in the early days of the pandemic. And so we published that work, and then eventually other institutions noted the same thing. And so if we know that the pandemic is disproportionately affecting children and maybe driving them to a potentially more severe form of type 2 diabetes, our lab is going back and doing the molecular work to understand that. So with support from the NIH and from the FDA, we're trying to use liquid biopsies from our patients to see if we can identify inflammatory panels that would suggest that they are having a reaction that may have them acquire long COVID or have long-term diabetes as a result of having COVID-19, and trying to understand the molecular damage that's happening to insulin cells to see if we can recover full function after COVID-19 exposure, to make sure that we can ensure the long-term health of children and adults that have experienced having COVID-19.
Is it known, as you were speaking, is it known why some children are vulnerable to this and some children are not, in terms of the COVID-19 infection and damage to the insulin-producing cells?
It's not known. We don't understand why some people are more affected than other people. And it's really hard to know that unless you can use markers that we can find in the blood ahead of time before someone has COVID, then to identify how COVID might have affected that. But we are trying to use those markers that we find in the blood very early during people's reaction to COVID-19, and then looking at how those markers change over time, and then correlating that information with their clinical outcomes to try to develop a better picture and understanding of that.
So it's really important about your work is it really connects well with other efforts here in research at Children's Hospital Los Angeles and the Savan Research Institute, looking at the impact of long COVID in research here going on in impacts on heart health and heart disease. So the work you're doing in insulin producing cells and pancreas is incredibly important. So what I wanted to do is give each of you get 1 minute, although I don't have a stopwatch, but I'm pretty good at counting, to just give us, like, you're talking to me. I don't know anything about what you're doing, and you want to impress me with the one key kernel of work that you're doing, of research that you're doing. And we're going to start with Dr. Vidmar.
Yes, absolutely. So I think the most important takeaway that I would share is that pediatric obesity is a major public health concern, and it is a chronic disease that is caused by changes in biology, genetics, and the environment, and it is not the fault of the child or their parents. And it requires comprehensive obesity treatment that includes lifestyle modification, obesity medications, and potentially surgery to ensure that we are preventing and treating life-limiting complications that could impact the quality of life and the health trajectory of these young folks over time.
47 seconds. That was perfect. I don't know if that was perfect, but that was really, that was a great summary. Dr. Coley, 1 minute to summarize the key kernel for me.
I've been taught by some very good teachers, and my patients are my teachers. I'll share something that connects with them. We talk about lifestyle and how do I get it across to them. I came up with a jingle, and the jingle goes this way. And Dr. Goran, maybe you can repeat it back after me. The jingle is, if it's sweet and you can pour, say it, Dr. Grant,
If it's sweet and you
and
can
you can
pour,
pour, kick it out the door.
take it out the door.
Kick it out the door. That's all I'll say. If it's sweet and you can pour, kick it out the door.
Well, I don't think anybody can top that one. Although we're going to ask Dr. Gorin to summarize in 1 minute,
Yeah.
without kicking the door in or kicking the door out, what you think are the really a takeaway message for the crisis that we're in now, the health crisis that we're in now.
Yeah. I think what I wanted to focus on was to say that we have the medications, we have the treatments, but we're not going to medicate our way out of this problem. It's really a societal issue that requires action at multiple levels. So with the Southern California Center for Latino Health, we're working with community to help communities develop better strategies. We're working with promotoras, for example, to educate them to deliver community health. We're working with families. Families need better tools. That's what we're hearing from them. Families don't want to bring their kids to the hospital. Families want to prevent. So one of my jobs is to keep kids out of the hospital. Sorry, but that's kind of part of our mission too, to prevent these chronic diseases. And the third thing is just policy action. We need better policies on things like getting healthier school meals where pizza is not counted as a vegetable, where the beverage of choice is clean drinking water, which is a human right, which should be broadly accessible for all kids. So I think we've got to work on those three different levels to prevent these chronic diseases.
That's great. And very important you mentioned policy, because I think that's where we know that has to be part of the solution for what we're dealing with as a society. But Dr. Georgia, you almost have the last word, because I might say a few things, but for the panel, you have the last word.
Okay, well, I'm going to take 60 seconds from everybody else too. And so maybe okay, never mind. I think the best way to articulate what my lab does is that we live in a translational environment here at Children's Hospital of Los Angeles, where not only do we do bench to bedside work, but we do bedside to bench and back to the bedside. And so our work is really driven by the clinical outcomes and the clinical mission of the hospital, which is to improve our patients' lives. And so my lab works closely with our clinical colleagues to try to understand the origins of diabetes from an insulin cell-centric type of way, or from an insulin cell-centric type of perspective. And we try to understand how normal stressors, whether it is dietary interventions and environmental interventions, early life stress, or diseases like COVID-19, or even genetic mutations, affect the way that people's insulin cells work and predispose them to potentially getting diabetes. And then we use all of that information to try to understand the molecular pathways that are going wrong and develop interventions to either stimulate or repress what's happening that's either wrong or right, to develop new ways to try to help people, and specifically help children with diabetes.
That's great. One thing I wanted to say, you've heard from 4 very smart individuals, totally dedicated and embedded in the research that they're doing, as well as the clinical care that's so important that we have here at Children's Hospital Los Angeles. We also do one other thing that's really important, which is to do training, the next generation of pediatricians, physician scientists, PhD scientists, to really take on the challenges that we've heard about today. This is part of the culture that we have here at Children's Hospital Los Angeles, to incorporate individuals starting in high school. In Los Angeles, we have high school students in various research groups and laboratories, all the way through junior faculty that are going to not just help us, but really drive innovative approaches to research that are going to make discoveries that we never thought we were going to be able to make. So that training part for what we do at Children's Hospital Los Angeles is so important. I want to thank each of you. I don't know if there are any questions that we have. We don't have any questions. So we do have any questions? We don't have any questions. We do have a question.
Question from Stat News.
Okay. Do you want me to stand back here? Oh, you're going to do it.
I am Lorenzo Benet, Director of Public Relations at Children's Hospital Los Angeles.
Start again.
Hi, I'm Lorenzo Benet. I'm Director of Public Relations at Children's Hospital Los Angeles. We're taking questions, and we do have one question from Stat News, and it's directed to Dr. Coley. The question is, as you develop therapies for fatty liver disease, what is challenging about this condition?
It's a very insightful question. Thank you for the same. And Lorenzo, thank you for sharing that question. I think the conundrum we face as individual scientists, individual laboratories, is that usually science is focused on a simple pathway or a mechanism of action, which is in isolation. And here we have nature versus nurture, and sometimes nature and nurture together impacting a disease. So what do I mean by that? I mean is that you have all these environmental pressures of cheap, calorie-dense foods that are highly processed on the backbone of genetic predispositions. And when those two meet, for us to be able to define therapies that are effective across the whole spectrum of our patient population, it becomes very difficult. So in the long run, we're probably looking at very personalized way of dealing with this. So when we talk about precision medicine, we understand there are certain individuals that will be more affected in terms of diabetes, and Dr. Bitmar and her team will help with that. There are certain individuals we can help by just preventing the disease to begin with, and Dr. Baran's initiatives in the community will help. And then certain unfortunate children will land up in our fatty liver disease clinic with extreme forms of fibrosis and cirrhosis. At that time, we will have to come to them with medications which are focused on reversing the fibrosis or reversing the inflammation. So it's not a one size fits all solution. And that's where this condition is challenging. And we have to put our whole community of scientists and physicians and researchers and community workers together on this problem.
Okay.
Are there any other questions?
Question
Is
up
it
here.
first?
Oh,
For Dr. Vidmar, we're talking about obesity medications.
Yes.
I know that the American Academy of Pediatrics said it was okay to start giving drugs like Ozempic to children. And how do you feel about that? There are so many new drugs. I'm asking the question about obesity medication. There are so many new drugs now with Mounjaro. Wegovy has been around. Are these okay to give to children? Because I understand that this is a lifestyle commitment. I mean, a lifelong commitment if you do that.
It's a great question. So I think, again, sort of based on what the American Academy of Pediatrics did encourage, the goal is comprehensive obesity treatment, which is incorporating lifestyle modification, but considering obesity medication if it is indicated. So you're correct that we do have FDA indication to treat youth that are living in larger bodies based on their age and based on the criteria that they meet, and that the tools that we have available are things like the glucagon-like 1 peptide injectable agents that you mentioned, which are things like Ozempic or Mounjaro. So again, I think that we do certainly use those agents here at Children's Hospital Los Angeles if they are indicated in concurrent use with lifestyle modification and our comprehensive treatment course. I think that we are learning more about what these medications are, how we can use them safely, what patient they are appropriate for. But again, I think we are emphasizing that this is a chronic disease, and diseases are treated with lifestyle changes, with medications, and with surgery as indicated. So just like in any other chronic disease model within pediatrics, we want to make sure that we are considering and offering whatever sort of treatment course is going to best take care of the child in front of us. So I think that it is a collaborative decision that we are making based off of the evidence that we have in front of us and the various tools that we're able to use in collaboration with the patient and the family.
And I would say that, healthy adults start off as healthy children. And, one of the goals we have as researchers is to put pediatrics out of business. I'm just kidding, of course. But you know what I mean, right? That prevention, just like we do in dentistry now, right? A lot of dentistry is about prevention. Pediatrics is moving more and more to that, to understand from research discoveries how we can prevent these chronic diseases and change the trajectories. And as Dr. Vidmar mentioned, lifestyle changes and Dr. Gorin mentioned it as well, Dr. Coley. Lifestyle changes are extremely challenging, as everybody knows, because it's behavioral modification. And that's really, really difficult, particularly in adults. The best chance we have is to do this in children, and we have a huge effort here at Children's Hospital Los Angeles in doing just that, together with the integrated approaches that we take. It's a great question.